Welcome to today's webinar. The topic for today is COVID-19 separation quarantine units and senior living best practices. My name is Savannah Romans and I will be facilitating today's meeting. If you have any questions during this presentation, please send those to webinars@directsupply.com. We will answer as many questions as we can at the end of the presentation. If we do not get to your question now, we will respond by email. Please note, the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should ensure compliance with your unique building, locality, and licensing considerations and consult with your compliance and legal teams. This webinar today will be recorded. Today's webinar will be presented by Kenn Daily, LNHA and founder of Elder Care Systems Group. Kenn has a long track record of leading people, building teams, and recommending best practices, quality control, and fiscal accountability for healthcare programs. With the recent implementation of CMS's emergency preparedness mandate, Kenn has worked with hundreds of facilities and individuals focused on being better prepared for those things we cannot control. Kenn has said many times, you cannot control the environment, but we can control the facility response. Today, Kenn is one of the leading life safety specialists focused on senior living and works throughout the country on life safety and emergency preparedness. Kenn has served nearly 20 years on the Ohio Healthcare Association Board of Trustees. Kenn has served as the chair of the OHCA's Life Safety and Disaster Management Committee. He also serves on the American Healthcare Association Life Safety and Disaster Management Committee, as well as the National Fire Protection Association Healthcare Committee and its executive board. A frequent and engaging speaker, having lectured nationwide at professional conferences, trainings, and other sponsored events, sharing insights on long-term care operations, quality survey, disaster management, and life safety code, as well as authoritating and editing numerous articles and professional manuals. Now, please welcome Kenn.
Well, good morning, and thank you for joining us. I certainly appreciate the opportunity to be working with Direct Supply and Tells on this really important issue during our initial COVID outbreak. We're going to go through a lot of material this morning and really talk about the separation or quarantine units and how to set one up. A little bit of background, as introduced, I am a licensed administrator and I am currently the interim executive director of Greenville Healthcare and Rehab. I have worked with them for quite several months, and regrettably, the facility currently has an outbreak of COVID. We've had more than 40 cases confirmed, including nearly 20 residents, and at this point, we've had 7 residents confirmed dead due to the COVID virus. So I certainly understand what is occurring and some of the things that I think many of you who may not have this issue, or even if you are early in this issue, would want to consider doing in terms of separating your residents' population. We did set one of these up immediately, what I'm going to describe. And again, this is simply a recommendation and it's an opportunity for you to consider. And it has been relatively effective, and I'll try to explain to you how that's been effective over the past few weeks. It's hard to imagine that just in a few weeks we have gone from normal long-term care delivery to what is today obviously one of the most profound moments in our careers in terms of how this has affected many of you in long-term care. So we're going to start off with policy and planning and preparedness. Again, every day we see the news and every day we see more reports about long-term care. It has always been the greatest concern of our regulators and our politicians that because of the effect this has on populations of individuals over age 70 or even 80, that long-term care, of course, is going to be targeted by the disease for what will be the worst case scenario outcome, which is resident death. And of course, we saw back in late February, early March, the initial long-term care center in this country, which is Kirkland, and I don't mean to focus on them in a negative light. None of us knew what was going to happen. I mean, who of us would have known a little over 6 weeks ago that having a Mardi Gras event among our residents was going to be potentially deadly? How many of you would ever think a magic show would be a problem? Or how many of you would have thought communal dining was anything but positive? And so what they did there, and many of us did up until the middle of March, who of us would have known that? So the idea of social distancing, canceling activities, suspending communal dining, and all of that has occurred really only in the past 3 weeks. While it appears, as today's reporting, there may have been some flattening of the curve, as they refer to, and it's interesting, and many of you probably don't spend a lot of time reading everything you possibly can, but I was looking at data from the Spanish flu in 1918 compared to COVID, and the curve, as we talk about it now, looked very similar in the Spanish flu, and of course 102 years ago they didn't know about social distancing as well, and so we are going to make a difference, and it will take time, to eliminate this, but I think what we can learn from the initial survey, and obviously the pain that the facility in Washington took, is really three things, and that's why I listed them: in failure to identify and manage ill residents, notify the Department of Health, and then of course sufficient backup plans. And so, when you think about this, and I know some of you may have heard me speak before on emergency preparedness, or others, this is really just part of your emergency preparedness plan. And I know what Direct Supply and TELS is offering in terms of checklists and some policies are things that I developed for facilities across the country as an addendum. It's a roughly 100-page addendum to your emergency preparedness plan, because if you've done a hazard vulnerability tool in the past, and many of you obviously have who are listening, you would have recognized an infectious disease outbreak was in your most likely things to happen, maybe the third or fourth, or in some cases, top thing that could happen in your building. But I don't think you necessarily internalize that to what we needed to do to prepare. The infectious disease program was really based around following a policy of following your county, listening to the state and federal government, which we've done tremendously. But it really was also about supplies and PPE and training. And so incorporating all of this into your emergency plan may be coming a little bit later, but it's better later than never, because honestly, guys, this is not going to end, in a few weeks, and we're going to look behind this and think, oh, this was a fond memory. I mean, this could go on, honestly, for months and months, if not years, in terms of this coming and going and ebbing and flowing. And so some of these things that we're doing, whether it's the N95 mask wearing, or constantly washing our hands, or social distancing, or limiting the size of groups, that may go on for quite a while, and really until there's a successful treatment and or a vaccine, because at this point, there really is no way to make the disease stop. And so, I think one of the things, though, and what this slide is all about, guys, is that when you listen to me and you listen to and read the CDC materials, and even within your own companies, every facility must have somebody who is the incident commander. Incident command structure was developed 50 or so years ago, and it's applicable today. It's applicable everywhere. Every state is an incident command structure, every hospital, every first response organization, and now our facilities have to do this. Some of you have listening maybe from states that have implemented this. California and healthcare associations have developed lengthy programs. When I served with American Healthcare, we were able to kind of mold those two programs together and create nursing home incident command. There's also assisted living incident command. But to be honest with you guys, in the end of the day, it's about simple leadership. You have to have a boots on the ground in the facility leader on a daily basis, managing your resources, your staffing, your PPE, and your response to this crisis. And that's a lot. You can't do this from home. I mean, administrators or directors of nursing or corporate leadership has to be in the facility. You can't do this remotely, guys. And so leadership is critical. And we're seeing that today. across the country as facilities need to have leadership to respond to this ever never ending or the evolution of this never seems to stop. And so leadership. So that's it's important. That is very important. And we'll talk about that at another time, I'm sure. But what I really want to talk about this morning and what we've done is we've created a conversation about setting up what we refer to as a separation or quarantine zone. And I want to explain first why we're using the word separation. As many of you know, or have thought about, is that we are obviously not constructed as hospitals. Hospitals in this country will have what's referred to as isolation rooms that many times will be set up, including the ability to isolate and or what's called referred to as negative pressure, actually exhaust all of the air to the environment. Well, unless you are very fortunate to be in a facility that has such a containment area, most of us don't have that. Thus, you cannot really create what's considered true isolation. So I chose the word after listening to a number of conversations and thinking about it, is that really we're trying to separate physically residents who are suspected to be affected or positives, or actually positive residents. And so what you're trying to do is create a zone where you focus the attention on the disease process and the recovery of the disease in a zone where everybody would be wearing the PPE and being mindful of the requirements. Whereas maybe other parts of your facility, because there is no suspicion or no positive residents, that you could operate more normally. And so I'll go through how that works, but this is all this is. I mean, it's just simply an opportunity, a recommendation, or a consideration of how to develop a separate unit within your facility that actually has a physical separate barrier. And that's how not just a red piece of tape on the carpet or something. This is going to be a separate walled area. But the walls, I don't believe, are sturdy enough. I mean, they're not walls where you can nail anything into them. It's made of visqueen, for God's sakes. But it is a physical barrier, and that's how we're going to describe this as we go through. I think it's really important to consider when you're considering a unit. And then again, if you don't want to consider a physical unit, that is fine. Every building has to go this path on their own. But you need to first identify staff working in the facility and in this area. As you set up an area, you need to think about having the necessary staff, the minimum staff necessary, and then hopefully you'll be able to, we've talked about in the past, doing resident-based staffing where you have the same staff caring for the same residents every day. And that's, that would be a wonderful opportunity. And if your staff's well enough established and have big enough numbers, that would work great. But what I'm suggesting is that you designate staff to work in whatever unit or area of the building that you designate to have COVID separation. And so what's going to be important then is that you're trying to then train and make sure those specific staff are going to be using the right PPE, because what is underlined there is extremely important to understand. And this is where I think some facilities misinterpret or kind of miss the mark, is that once you have a known positive case, or you have somebody who's suspected of COVID, that staff have to wear the gloves, the gown, the eye shields, and the N95 mask or higher. And I always, the government says if available, because this language came straight out of the CMS focus survey for facilities. And so, but if available, I mean, you're not going to send somebody in. Let me just put it this way: you're not sending somebody in to care for a COVID patient who doesn't have these 4 items. I mean, unless it's an emergency. I mean, the N95 mask is the number one piece. The gown and eye protection and gloves are the other 3 pieces that have to be. I mean, this is the minimum in my mind. And this is the minimum my staff wear every day in the unit and in other parts of my building today when we're caring for residents. And so understand that this is really what the government, the CDC and CMS expectation is. So one of the things about having a unit or a zone is that we are trying to also maximize the use of PPE so that it's not all over the whole building. We're using the most of the PPE back there in my unit. My unit is 24 or 25 beds large at this point. And so the idea is that we're trying to maximize the use of what limited resources we have. And then, of course, all the other bullets there go to the issue of things about our resident care. We've added the room numbers to the outside of the windows. Now, some of you who have been trained or have been thinking about this previously may have done this for active shooter response. It's also a very good way to deal with active shooter for your facility, is putting the resident room numbers on the outside of the window. But we've done that now relative to COVID. So when we tell somebody who's moved down to the unit, we tell them remember what room they're in, they can find it relatively easy. And obviously we're communicating with staff. I probably in-service my staff, at least floor coach them on a daily basis. A more formal in-servicing is occurring at least weekly. And of course, as we change things, I've in-serviced them or met with them frequently. Hold on a sec. I got to take a break because I have a knocking door thing. I'm so sorry. I'll be right back. You're fine. Yeah, staff needed some more PPE. And then, of course, obviously, prior to moving residents, we are trying to make sure that the families are aware. I'm calling them. One of the things that has occurred is that a number of my department heads also have gotten the COVID-19 virus. So my social worker's out, my 3 activities staff are out, my office manager is out, my HR director is out. So we have limited ourselves to my marketing director, my MDS nurse, and I, along with some of my key management nursing staff, are the ones here. So we've picked up and, we're making phone calls to residents. Now, some of the materials you'll need in terms of building this, a little DIY moment, is visqueen or plastic covering. The visqueen, of course, needs to be the height and width of your corridor. You don't want to have to seam this together. So it has to be one solid piece. So I think the piece we actually bought was 20 by 50. And then obviously we had to cut it down. And then, of course, it worked out just fine, as you'll see. The visqueen should be at least 5 millimeters thickness at this point. I think ours actually was 7 millimeters in thickness. And then you'll see the bottom things, this painter's zip. It's painter's zipper. It's a zipper. If you've ever seen this, guys, or if you're listening, you can go to like a store. I don't know if Direct Supply. If you guys are carrying these zippers, but I know that other companies that sell paint have this Vosa visqueen and the zippers where you put the zipper in the middle of the visqueen. Once you get your visqueen wall up, and then it sticks up because there's both sides of the zipper are heavy duty adhesive tape. And you put that up, and then as you move the zipper, the middle part of the zipper up or down, you take a sharp knife and you cut it, and that creates the opening in the zipper. And so then the zipper obviously closes the plastic as you open it or close it. So it works really nifty, and it was really easy to install. Now, of course, we also had to use 2x4s. So incredibly, we screwed in with those 3-inch drywall screws, 2x4s into door frames all the way around the door. And I'll show you pictures in a second. And then we actually rolled the visqueen into 2x2s and nailed staple gun that. And then we nailed the 2x2s to the 2x4s, or screwed them to the 2x4s. So it's not difficult at all to create this. You just need, and then duct tape we used all the way around the outside of the wall itself to provide any seal around. So we're trying to reduce the air. I can't guarantee, and it certainly is, again, it's not an isolation unit, it's just physical separation. but we are trying to reduce the amount of airflow from the separated area to the general parts of the building. And at the bottom, I'll show you how we use a 2x6 footer to hold part of the wall down with the concrete blocks. And so our original design was a footer all the way across the bottom, but that doesn't work well, and I'll explain to you why in just a second. But these are the basic elements of our Visqueen walls. There are 2 of them. So when you're buying the material, you need to think about enough for 2 walls, because you're actually creating, in a second, I'll show you how we're creating a vestibule. And so you're creating a landing area, vestibule area, and then the second wall is where the isolation at best, or the separation at best, starts. So I'll explain how that works in just a second. But this is the general list of supplies that we use to do this. So you see my initial unit. The initial unit was 15 beds, and I had to move the wall down to the total end of this hallway. We refer to this as North Hallway. So you'll see initially I moved it and I designed it so it would not in any way, shape, or form interfere with a fire door. As much as some of you are questioning building walls in a corridor, which under the best of days, as a life safety code specialist, I would tell you we can't do that. And I certainly, if you have questions or concerns, you could ask your fire marshals. They may have concerns with this. Now, I would tell you that it's plastic. You can walk through it. And one of the things I strongly urge you to have in your design is an exit door, a direct exit. So a direct exit to the outside. Now, I understand that when you exit these rooms, you should be able to go left or right, and you should go to an exit, and that's true. And I realize that if you went to a certain direction, and you'd have to go through the plastic in the walls, which would be an impediment. But in creating this separation, we've done it with plastic, not drywall. And honestly, it can be torn down in a rather number of seconds. So it really is not as permanent a structure as one might consider. And as you'll see at the other end of the unit, where it says exit, that is a direct exit to the sidewalk, to the driveway, which would be a direct exit to the outdoors. So we didn't block a fire door, and we never have. And then you'll see the first wall. The first wall is there, and that's where the beginning of the unit is. And then you'll see the area located called vestibule. And what I refer to that as is that you'll see there is a patient room that is across the hall from the word vestibule, and that would be where we would have some supplies stored and some materials and linens. And then we also have that clean room for storage and staff changing. So when we created this, we were able to create space that has both storage and changing. And in that large room, which was actually activities room, there's a table for staff to relax. There's food in there sometimes, some soda pop. There's a computer in there. I think there's a TV. So there is a space for staff to be in there. Because one of the things that's important about the separation unit is you don't want that many staff coming into this area. I've limited it to nursing only, and then one housekeeper. So you're not having kitchen staff. I don't go back there. I've been back in my unit twice in the past week. I had a family question that needed to be answered, and I needed to go back and see a resident. And then last Sunday I was in there as a maintenance guy, and I was fixing a bed. So I had to go back to the unit. But no, in all reality, is you're trying to maximize the use of your PPE. So fewer people wearing it is actually going to extend the life. And then you don't want everybody traipsing through it. I mean, we can talk about the word exposed to a COVID versus in the presence of. You're only exposed to it when you don't have PPE on. You're in the presence of it, and it's safe, theoretically, if you're all PPP'd up. So, when you're wearing your eye protection and your N95 mask and the gown and the booties and your gloves, then you're supposed to understand that if you're doing it correctly, and then ultimately you don it and then you doff it correctly, that you should be safe, relatively safe. So we're trying to limit that. We're trying to limit the people in that unit. So we have that clean room or relatively clean room for staging and rest. and different supplies. And then you have the second wall, and that's really where the second wall where people enter the isolation area or separation area, the zone, as I refer to it as the zone. And then obviously down the hall, all the way to the exit, are the patient rooms where there are residents in each of these rooms today that are positive for the COVID virus. As I said, I think we have almost 20 residents that are positive. And this is my original design of roughly 12 beds. We had to tear this first set down, and we had to rebuild it at the farther down the hall. So there's the entire unit, it's an entire 25 bed unit. So we lost the clean room, but we still gained a patient room that we're using for staging and storage. But we didn't have this. And these are not requirements. These are just things I would strongly recommend. A place for staff to change, don and doff, have clean linens, that kind of thing. And so then we have these residents. There should be, for instance, in the corridor right here, well, you can't see, I'm pointing, and right here in the vestibule. So right where the V is in vestibule, there is on both sides of the corridor, alcohol sanitizer units on the wall today, so that everybody knows that when you go in and out of the unit, that you're sanitizing in and out immediately as you're removing your gloves, and all of that. And then, of course, if you could possibly turn off your air conditioning or your furnaces and consider, reducing the airflow in and out, that would be fantastic. And then I've actually considered turning on all of the bathroom vent fans to, you would be sucking out some dirty air. Now, it may have some limited utility because if you're venting it to the attic, it may not be actually all the way onto your building. So again, it may not be that effective, but it is anything that we can do to increase or decrease the amount of COVID in the air and droplets, and trying to keep the air moving and exiting, the better. And so I think it's something to consider. Now, as incident commander, again, in smaller facilities, incident command should be the administrator in most cases. And so again, you're boots on the ground, you're in the facility, you will need to develop, in terms of your separation areas, how you're going to deliver food, mail, linens, and trash, supplies, et cetera. And I'm going to try to go through all those things that we have done in our unit, but you certainly can have, and you will probably have, some other oddities and or your own way of doing it, which is totally acceptable, because at this point, none of this is required. This is all just another way to create a separation in an most effective way possible. So here's beginning of the unit. This is our first wall before we head to the sign. So you'll see it's sealed off. The ice chest actually originally was not in the unit. That is now in the unit, by the way. The first unit didn't have an ice chest, and we realized that was a mistake. So we took it, but you'll see it's simply Visqueen with the zipper running down the middle. And again, if you've never done this, it's really easy to install and create this. Now today, you'll see there on the right side, all PPE required to be worn before entering. That is on that first piece of plastic today. So I do expect staff as they enter the vestibule to be donning all of these items from our supply. Now, in our building, because once you have your first positive case in your facility, you will move from allowed to wear or encouraged or required to wear a surgical mask or even those homemade masks. Once you have a positive case in your facility, you'll have to wear N95 masks. So for us, our N95 masks never come off. Now, obviously, I'm not giving this webinar with my mask on because then I'd be mumbling, but I do have 3 masks on my desk currently, because unfortunately, I've used them at different times, and they do get worn out, and so there are places that can actually sterilize them, but you will wear all this. So once I enter, the 2 times I've been in the unit, I come in with the mask on, see? Mask goes on, and then as you enter the unit, there's gowns, and I'll show you a second, hanging, there's eye shields, and then there's gloves throughout the unit to put on. So that's the very first wall of the unit in our facility. And you'll see this picture is really, again, I would install the zipper from the bottom going up. Originally, my idea was to make the zipper going down. I'm sorry, it should be from the top to the bottom. So you're going to zip down. Originally, I had zipping up, but that makes the opening very small, and it's even harder to get like food trays through and such. So we changed the design from the first wall to the second wall. So what we did originally is that footer at the bottom of the concrete block was on both sides of the zipper to provide a very tight seal at the bottom. It was very effective, actually, in creating a seal, but it became very difficult in some cases to get materials and staff through the opening. And so what we did is this 2x6 is holding down that left side of the visqueen wall and zipper side with a concrete block. And actually, we have it covered with a old piece of white sheet, so it's white, to dress it up a little bit and not make it look so industrial concrete. But I took that off for the photograph. But you'll see that was our original way to hold things down. Because what happens then, if you do that, you're able to do this picture, which means when the zipper is all the way up and you pull the sheeting back, the right side opens much wider and allows for staff and some materials to go into the unit much more effectively than if it zips the opposite direction. So we have designed it that way today. Then you'll see when you enter, these pictures are really just from the plastic being pulled back, and you're looking inside the vestibule. So the vestibule area is the area, again, with the storage area room, or areas that can be used for donning and doffing. Again, there's a treatment cart there in this original picture because we didn't have all the space we needed to have all the equipment in the corridor. This is the original pictures. Our current unit is 24 beds long and almost 80 feet long, and so there's all the equipment is sitting on the unit now. So things have changed a little bit since our original construction. And then, of course, this is looking from the second wall. So you look down the hallway here and you'll see there's a lot of stuff in it. It starts looking like an ICU pretty quickly. We're trying to be, mindful of both sides of the hallway, but you'll see those tray tables and cart are on that side, the med cart. So we'll talk about supplies that you need in your unit in a second, but you'll see all the way down the corridor, there is materials in the corridor, and we try to keep it clean. Nursing's done a terrific job of maintaining the space. And I said I have housekeeping going in there to the space once a day, one person, and cleans the unit to try to, obviously provide a more hygienic and clean environment. And then, of course, we have this. Now, you might think this is ironic, but this is one of our clean rooms that's in off the vestibule, and we have I have screwed up a clothesline. And I know you're thinking that's unbelievable, but that's what we're in now. So all of that PPE, whether it's eye shields or the gowns, or even sometimes we hang some masks in there, we're trying to extend the life of these things. So we hang them, we spray them when we have had Lysol type products so that we can try to clean the material, the paper material, a little bit better. But I really felt that hanging these was a lot more effective than laying them on places in rooms or anywhere. So laying didn't seem to be that effective. You can't see it, but there's a window behind the hanging PPE, and we have the window cracked, provide some fresh air, and trying to dry out any moisture that has, from a cough or a sneeze accumulated on any of those pieces of PPE. And at this point, it has been extremely effective at extending the life of our PPE. I don't know how many weeks this has added to the life of this stuff, but it is adding weeks and weeks to the life of this material. Now, within the zone itself, as we go through this, so you have to think about in that zone, you want to have a trash can, you want to have dirty laundry barrels, because You're going to want to collect that stuff. And I'm going to go back. I'm sorry, I need to go back. And remember, guys, when you look at this drawing, once you're in the unit, you're going to want to collect the linens and trash. And we are using that exit out there. Now, that's not an entrance anymore. Again, when we locked down our facilities, all entrances other than the front door was locked from getting in. So people can't get back in the unit this way, but all the barrels are going out that door. So linen and trash are exiting. And when the staff exit and go to the right, they're actually within 50 feet of the dumpsters, and then probably 200 meters around to the back door near the laundry. And so they're wheeling that stuff around the building and not traipsing it through the hallway. That's what we're trying to avoid, of course, is moving it through the corridor and spreading any type of infection to the non-infected areas of my center. But then also within the unit, there are tables and carts for supplies. We do use, and I'll explain in a second, how we use carts to transfer the dining trays and deliver trays. So we are doing that. There is a barrel for anything dirty, pieces of equipment that need to be re-cleaned or wiped down. That has not been as effective for us because there's not a lot going in that, but we did set aside some place to store dirty pieces of equipment that needed to be cleaned. Obviously, you need a lot of wipes for resident or for staff shoes. We did have some booties originally to cover the shoes, but we have run out of that. So that has been better to just use the wipes or the spray, the Lysol type sprays for gowns and other items. Obviously, there's hand sanitizer and liquid soap in every resident bathroom and every resident room. You might need extra trash bags because, as gowns do get dirty or ripped, you obviously getting more trash in some ways. We did get a Medicaid. We did get a medical cart, treatment cart and medicine cart for the unit. So we were very fortunate to have a good relationship with a pharmacy who's supported us and provided us some extra equipment. We designated, a vital machine sign or the machine. We have a crash cart, which is outside the unit. There's a housekeeping cart in the unit separate now. You have office supplies, Sharpies. You have obviously clean linens being stored in the unit and a cart, and then lift equipment. So all of the stuff, the reason we did it this way is I didn't want all this stuff leaving the unit. Many of you, for instance, share your lifts. You may not have that many, standing lifts or Hoyer type lifts. And so, we share them in our units and in our facilities. Well, you don't want that with the COVID. You want a designated piece of equipment because you don't want to have to clean it every time. Now, we are already wiping it down as frequently as possible between uses and such, but you wouldn't want to inadvertently use it on a patient with COVID, not wipe it down, and then use it for a non-COVID patient. And somehow they end up with the virus. So by having it dedicated, you're again limiting the spread, limiting the use by non-virus infected individuals. And then, of course, lastly, there is an ice chest in there now. As I said before, the ice chest we left on the outside, which is a problem, so we put one on the inside now. So, but this is generally the list of items that we are keeping inside the unit and keeping away from the rest of the building at this point. And so at this point, it has worked very, very well. But again, my unit is 25 beds large with 24 resident occupancy. And so it's different than some of you might be thinking of, creating a 5 or 6 bed. So you have to think about how you're cleaning and maintaining equipment going forward, because at 5 or 6 beds, your hallway may only be 15 feet long or 20 feet long. So you may be really limited in the amount of space you have to get it dedicated equipment. And then, of course, going in, one of the things that's been the most effective in this, and many of you who's listening who are healthcare professionals, we've all been through the in-services on hand washing and infection control and talking about the SARS and the MERS and the novovirus and the H1N1, but may not have actually internalized it as we are today. And maybe you're not even internalizing all of this. Understand, you do not want a single case in your facility if you don't have one today. And you must do everything possible to avoid having a case of COVID in your facility, because one case in your facility begins the slippery slope of the second case and the first staff and the second staff and the third case. And the next thing you know, you're in my situation. I have no idea who patient zero was. We have done everything possible. We have adequate supply of PPE. We always have. We've had incredible relationships with the health department locally, the health department in the state of Ohio. We've had tremendous medical direction by my medical director and other doctors in our region, and it still spreads. I mean, you know what? People make mistakes. I don't know. I have not gotten it, thankfully, but who knows what you touched? Who knows who's next to you? You never know. But residents, guys, we can't let our residents get this. You have to be vigilant. I mean, there's three things to think about now: vigilance, vigilance, vigilance. And you don't want this. You do not want this in your building. So what's been great about having the separation unit is nobody ever goes in and passes that second wall not totally prepared with PPE on. They're wearing all four things constantly. I mean, I don't really need the signs on there to remind them. No one is going into that unit and thinking, oh, I can go in and not really have anything on. I mean, we're good about wearing masks throughout the building almost 100% of the time now, but I'm telling you 100% of the time, for sure, staff's going into that unit and they're taking it seriously and wearing their PPE. So it is something that, if nothing else, it's a huge notice to be mindful and respectful of this disease, and wear your PPE. Now, of course, we're talking about, I said, consider make sure they go to the restroom prior, because my unit now has a bathroom, but it didn't originally have a restroom. So the idea is that if you don't have a restroom dedicated for staff to use, you don't want them going in, because you don't want people going in and out. So, take your supplies in. Once you go in, stay in. Care for residents in the unit. You don't want people going in and out, on and off, donning and doffing stuff. I mean, that's ineffective. That's inefficient. It causes the decay of your PPE by ripping. And so, you want people to go in, stay in for a while, do the work, care for your residents, and then come out. Obviously, with PPE, if it's damaged or soiled, dispose of it, in trash cans that are provided on the unit. If not, I expect it to be hung. We try to spray it. We have some Windex back there for our eye shields, because they get kind of dirty sometimes too. And so, then obviously dispose of your gloves appropriately by taking them off the way we've been taught, so not to infect ourselves. And then we all leave our masks on. We don't take the masks off ever. And my nursing staff never does. I mean, I'm in my office right now, so at this point, I'm not wearing it, as I said earlier. The food and hydration process, again, a little different than the other processes. We are, still serving resident food on regular trays, on regular plates and dishes, because you guys, we've had illnesses and viruses in our healthcare centers in my career all 35 years. I mean, we started with the AIDS virus. We've had SARS and MERS and novovirus and all the C. diffs and all the other stuff. And so we have managed all of that without having to mostly interrupt the use of regular dishes. As long as your dish machine has the right chemicals and is for hot water is going over 180 degrees, 185 degrees in the rinse cycle, it is fine, because we bring the tall tray rack down to the unit, and then the trays are transferred to a cart, and then the cart is used to deliver the trays to patient rooms. Reverse is done, and then that whole unit, the door, the stainless steel door gets closed on the tray cart, the tray cart, and then it's returned to the kitchen. The dishes are clean, staff's wearing PPE, and then the cart itself is taken out back and scrubbed down real quickly. I didn't want to go to disposable plates and dishes and forks and all that, because, well, one, it's extremely expensive, and two, it would create an enormous amount of trash that we're really not ready to do that yet either. So, and at this point, it has worked very well. My staff and I were out in the back today cleaning off the carts from breakfast this morning. So, and they're doing a wonderful job as well. And then, of course, As I said, the ice chest is in the unit now. We're bringing bags of ice in, and then we're just filling that with ice, either from our machine in a bag, or we're buying ice bags. So either way, but we're bringing ice and then water. We are using styrofoam cups to serve water in. And then, as I said, linen and trash. Again, dirty linens placed in bags. Do not overfill them. Do not make them too heavy, because we are wheeling them outside and then around our building, about probably 150 meters around our building, to the back door where the laundry is. As I said, we have a single entrance. I don't want people violating that, but there's a few exceptions to that. One is this exit door right off my separation unit. We use that to exit the trash and linens, dirty, and then the back door is allowed to be opened to collect the linen to be washed in our laundry room. But we're doing everything we can, not overfilling trash cans, not overfilling bags. We're making sure that they are, appropriately covered when they're in use. And then, of course, they're bagged, they're tied off before they're transferred. We're doing the best we can to clean all the room's trash. Do try to make sure nothing ever overflows. And then, we're trying to return all the items through the laundry. Again, laundry washes things. And again, they pass things through the first wall to a cart that is then taken to the unit to deliver to the resident rooms as necessary. And then lastly, I think that, we have just a number of websites. This actually was created by a number of sources. If you're just curious about contacts or information, I think there's 4 slides here on PPE and face coverings. There's one on infection control for COVID. I don't think I listed it, but if you're curious, there's a survey and certification memos, or what we refer to now as QSO memos, quality service organization memos. QSO memo 20-14 relates to nursing homes and COVID, and then 20-20 is for all operations, and that's a whole nother webinar. But that's where survey operations are interrupted. But mostly that's really related to the infection control COVID checklist and the COVID focus survey. And then there's healthcare personnel guidelines for risk assessment, criteria for personnel in the confirmed suspected cases. Again, a lot of these are considered interim guidances. I mean, obviously, most of this, if you go back, the first memo from CMS was only in mid-February on the COVID virus. It's been less than 8 weeks, and it's gone from literally 0 cases in this country to, obviously, we're what, over 250,000 cases, with probably some 40 or 50,000 cases in nursing homes or senior living in this country. So, in just a couple months. So it has grown quickly. Obviously, our populations are large, with millions of individuals in this country getting home care, assisted living, nursing home, independent living. But still, it is growing rapidly. And as I said before, what your goal is, if you're listening to this and you don't have a case, is that you don't want a case. You don't want your first case to go through all of the requirements and expectations of managing that case, and for the fear of the fatalities. Like I said, I think I have 18 confirmed cases in my building, and 7 of those people have passed away. So the death rate of my facility's residents is extraordinarily high. And I think that's what we're going to see in many facilities that end up with this. And there's nothing to stop it. There's no treatment, guys. I mean, right now we're giving Tylenol and fluids and as much comfort as we can. And the last set of slides, last thing, is just long-term care services and supports. Again, COVID-19, long-term care facilities, nursing homes, and alternate site and location isolation sites. This is if you're going to set up isolation in the whole building or a whole unit. And again, it supports what we talked about here in terms of setting up an area within your building. There's lots of states that talked about doing this or encouraging facilities to do this. So certainly as an opportunity, I certainly appreciate the opportunity to speak with you today. Again, if you have questions in the future, I believe, as you'll see here, webinars@directsupply.com is where you would direct questions. I believe that Direct Supply tells staff and I will be going through all these questions over the next few days. And then Tuesday, early as next Tuesday, Tuesday, we'll be posting those questions. So I certainly appreciate the opportunity to be here today. And again, I look forward to having your questions. Thanks.
Thanks so much for that awesome presentation, Ken. We do just have a couple questions that were sent in earlier.
Right.
After being tested, should a staff member come into work?
Oh, that's a great question. Yeah, that's a great question. And I think the major guidance is once they've been tested, you need to find out whether they're positive or negative. And that should, if you've done things correctly, and I say you as a facility have done things the way you can do them. If you're a skilled nursing home or a licensed assisted living in your county, you should be telling them first who you suspect of being positive. And then they should set up the testing, because that testing should be able to go to your state organization labs, which give you 1 or 2 day turnaround. If you simply send them to a testing center, like at a university parking lot or a hospital outside, you may end up with a vendor that's doing the testing, which is completely reputable, but it may take 2 weeks. I mean, my original testing of my staff person was occurred on April or March 20th and came back last Monday. So it took 15 days to get it back. So in the interim, she did not work in my building because I was following the 14-day setup. Now, of course, I can wait. When I've tested my staff, it's all of a day, and then you go from there. But remember too about testing is really when you're thinking about staff staying out of your facility, you got to think about when their symptoms started. This testing has really no bearing on when symptoms started, because ultimately how long your staff stay out is really based on, has it been 7 days or more since symptoms have started, and in the last 3 they had no symptoms. So I don't care if you want to follow the 14-day standard of like what we would do is self-quarantining at home before you're quote unquote ready to go back to work, or even 7-day standard. Either one of them always require the individual to have no symptoms of any kind for the last 3 days before returning to work. So that's really the important thing, is you cannot at this point allow staff who have any of the symptoms, so shortness of breath, cough, the sore throat, the headache, or the fever. And the fever, as I talk about, I think it's 100 degrees. I know the federal government says 100.4 from the CDC, but I'm not convinced temperature taking is as exact a science as one might think it is, because I think all of our thermometers are a little sketchy, some of them. And so I use 100 degrees as my threshold, and that's what I'm asking my staff. Staff's telling me I want to come back, but I'm at 99.9. Well, that's a little close. If you're at 98.8, 98.7, that's normal. So if you're at 99.1, what other symptoms do you have? So it's really an administrator listening to their staff person, interviewing them, and then tracking staff. You got to track all your staff illnesses. But coming back to work if you've gone as far as testing, you need to stay home until that test result comes back.
Gotcha. All right, makes total sense. So I'm just going to shift gears and give Dustin presentation rights while I ask you one more question.
Sure.
In the conversations with senior living communities, senior living executives preparing for this information, there was a lot of discussion around the expansion regarding like the number of rooms, et cetera, and flexibility required of these barriers. Do you have any advice on how to prepare to expand better?
Well, that's a great question too. And as I said early on, my original drawing shows just 12 rooms. And so I made this gentleman, his name's John, and I and Kyle, my HR, we put it together, and we built the first wall. It went up really quickly. We were done in a couple hours, had everything done. And then of course, I had to move my wall when I had an additional 8 residents come back positive in one day. And so I said we needed to move it. And so we moved it down to the end of the hall. And so we had enough supplies for a second set of walls already bought into my building, because I always figured things would get damaged, and we just used that. In theory, it potentially is movable. I mean, it's plastic and some wood, and you screw it, unscrew it, and I think it would be movable, but it just seemed I didn't make it to be movable. And so a second wall had to be purchased. I mean, the material had to just be purchased. And I don't really see it being like that resilient to be moved, but I mean, it might be, but I didn't test that part of it.
Gotcha, totally.
It's cool. Yeah.
All right. I'm sorry, one more question that they just keep piling in. What considerations what considerations would you give memory care related to separation units?
Wow. Somebody else asked me that yesterday, and this is like the impossible question. Because memory care, I don't think it really lends itself well to be a separated unit because it's already a unit. It's typically potentially a locked unit or delayed egress type entry unit. So it's already by itself a unit with direct care staff being already assigned. The problem, of course, is I think that dementia units are not going to be well set up for residents to be wearing masks and not touching things. And so it is a challenge. I really think those units need to be, they're already kind of set up as units, so they need to be kind of isolated. Because if we get into, once you have, even inside the unit, no residents are going into my hallways there. So all our rooms all the rooms of the residents that are positive, they're in their rooms and the doors are shut, which doesn't really seem to be it's totally counterintuitive for an Alzheimer's area, because we're trying to keep laying eyes on people, trying to engage them. And I don't have an Alzheimer's unit, so I have no experience in this situation, but the unit itself, the Alzheimer's or dementia unit, I think is already an isolation unit by itself. And so my concern is one case of COVID, everybody gets it. And that there's been some anecdotal stories about that. And so I think it goes back to staff being vigilant and wearing PPE, wiping down everything possible, and then of course trying to limit resident to resident interactions. I think there's a conversation to be had about hospitality aides, additional staff in those units during this time. I know Medicare's giving us extra money. Most states are going to provide extra money ultimately in their Medicaid funding for care. Everybody has to work that out individually, but I really think that a few extra staff supervising those residents is going to be necessary to be vigilant in trying to keep the separation, because it's not a natural thing for a dementia person to stay 6 feet from everybody else. I mean, there's nothing normal about that. So they think they're really under the gun here. And so, but the unit itself is already separation. So I would consider that potentially try to keep it that way. I mean, I would keep them together and away from everybody else.
Gotcha. All right. Well, thank you so much, Ken, for all of your time. And now for anyone interested in learning about how direct supply TELS can help, please help me welcome Dustin Teskey.
Good day, I guess. Thank you, Ken, again for your time, for your expertise, and for your contributions in getting this really relevant and timely information out. I don't want to spend a lot of time doing promotion as we might do on some of these webinars. I want to quickly tell you different ways that we have available through direct supply and TELS today to access this information and really put it into action. Before I do so, if there are additional questions, please continue to send them in through the webinars@directsupply.com email address you see on the screen. We'll be consolidating those and responding to attendees with a shared consolidated list when we provide the link to this video, along with the slides later early next week. So, again, really appreciate Ken and the guidance he's provided, not just as an expert, but by someone who's living, breathing this on a daily basis. The information shared with Ken, we've had a very fluid discussion over the last 2 weeks with Ken, with dozens of others in the senior living industry as we kind of consolidated and compiled, for lack of written policy and guidelines related to the separation units. We've really strived to capture what others are doing and create tools that can help put this directly into action. And the way to access that is through TELS. And although this is a TELS focus at the onset, you do not have to have TELS access today in order to gain access and take advantage of this great action-oriented information. For those of you that are TELS users, you know that you and the other 13,000 plus senior living providers make up a network of expertise that consolidated together really form the backbone of these best practices guidelines. So we appreciate your input that you've shared over the last couple of weeks, and Ken, as we develop this. The best and easy way to gain access to that through TELS today, if you are a TELS user, is within the training tab. So If you're in TELS as a building user, you'll see across the top of your tiles a couple different tabs to access. The far right one is always training. And as you can see on my screen here, the top left corner, we've dedicated now to COVID-19 resources. The information shared today, along with the emergency preparedness manual that Ken referenced earlier, that he's compiled over 100 such pages specifically to COVID-19, are out there as of right now. So gain access to this and a ton of other critical, relevant information, including regulatory guidance, directly from the training tab in TELS. Not just theory, we want to put policy into action. And so the best way that we can help you prepare your communities today, from a regional corporate level, or as a facility administrator or building level user, is to take advantage of TELS checklist templates. So TELS checklists take information and guidelines like the helpful hints and best practices shared, created by Ken, serviced by the rest of our senior living executives, and allow us to put that into an action-oriented checklist, as you can see on the left side of the screen here. We've actually created 2 in the last few weeks. A lot of credit to Sue Levin and the product engineers at TELS to take this great policy and information coming from CMS, the CDC, or again, in conversations like this, and really drive practical checklists that allow you and your buildings to customize on solutions for your organization and quickly put policy into action. Specifically, the value of this, as you look at these checklists, is that you're able to take this template, either one of the 2 that I just mentioned, customize it to the unique needs of your organization. So while we lay out best practice and policy, you can actually say, this is my organization's direction on that, and this is how we want to respond. We've included the important regulatory information right within information buttons. You remember the nice little eye icon that generally states this is where you can find information related to it. So along with our section headers, along with our actual instructions or tasks to complete, you'll find helpful regulatory information and guidelines right in there for some of the areas that we focused on. And for our checklist for the separation units, you're going to see 4 main sections. Those relate to planning, as Ken relayed earlier, staffing considerations, also discussed today, required and dedicated equipment. This is a unique one. What we've actually done within the TELS checklist here is included links directly to Direct Supply Network, and we'll touch more on why that's valuable in a second. But we wanted to give you quick and easy access if you do need to attain equipment, and to relevant information as to the availability and lead times related to said equipment. Lastly, and probably most importantly, once you've created your checklist, you can push that out across your organization to the communities that you're responsible for, or as a facility administrator, you can assign that to an infection preventionist or your maintenance director to get to take action. Within that, as they actually move through each individual step, they can confirm or deny, reply back with a very visual thumbs up, thumbs down response. Within there, you can take notes, you can take photos, you can dispatch work orders, you can assign to your budget, or if required, you can actually send this out to TELS Billing Service as a service request for an outside service provider to respond to. Once complete, you're actually going to receive a summary that's available as a PDF to both share and save or warehouse for later sharing with state surveyors or whoever might inquire on it. Also a great educational tool as you communicate across your infection team, what it was done and how do we respond to this. I want to really make clear how you can access this. So if you're a corporate or regional folks, you already know about the site visit tool. Odds are fairly good that you're using this today. You're going to access this the exact same way. When you enter the dashboard within TELS, you're going to see site visits tile in the upper left corner. From there, you're going to go click the button. It'll take you to all of your active site visits. And in the upper right corner, just as like you would with other site visits, you're going to click Create Site Visits, and that'll allow you to access the templates you've already customized for both the COVID-19 focused survey or for today's separation unit checklist we're discussing. Lastly, you're going to select the facility that you want to apply that for, and then click Select, and from there, you're going to move forward. If you're a facility user, if you're an administrator, executive director, infection preventionist, clinician, or maintenance director already using TELS, everyone can access this great new tool. With the only one who's restricted is those that have work order only access. So not your dispatch desk or your front receptionist, those folks. But you'll see a pop-up now as you enter TELS today, and that pop-up is going to take you right to the site visit template and allow you to customize for your building and then put this new plan into action, assigning it to the maintenance director, whoever you want or need to fulfill it. So lots of great ways to directly apply the expertise and guidance created by Kenn and circulated across the 13,000 senior living providers that make up the network of TELS. And we want to make sure that you have access to all that. If you have questions and you're a TELS user today, reach out to your TELS CAM or TELS salesperson. Or if you're interested in learning more about TELS, this is a 15-year plus relationship that we've had specifically with senior living. And we want to give you the benefit and the expertise available through that network as well. Also taking advantage of great online tools that can help drive work order optimization, regulatory compliance, or asset management. Contact your account manager at Direct Supply for more information, or you can email the request@tels.net email address you find on the slide as well. Lastly, you don't have to be a TELS user to take advantage of this information. We've taken this great TELS branded resources, and we're going to make it available in the public domain as well through our Direct Supply network. If you visited our website in the last week or two, you'll see that we've actually dedicated space for a COVID-19 landing page like much others. As of this week, it's been redesigned to be easier to navigate. You're going to see 3 individual sections: product information that'll help you get to timely information related to stocking and the right relevant products so you don't have to go search and sort. Industry expertise, this is where we're linking out CDC, CMS guidelines, a bunch of the information that you're probably seeing from ACA, from Leading Edge, and a variety of other groups that we're interacting with as well. We wanted to make a warehouse and repository to quickly sort and navigate through that there. And then ideas and expertise, which is an area where we're taking information like this, curated by Direct Supply or TELS, and then putting it out there on the site as well. You'll see on the right side, I've provided a sample of what will be a PDF of the checklist that we're creating for TELS. Unfortunately, it isn't going to be as actionable as what you'll find in TELS, but it is the same great guidance created by Kenn, circulated against those conversations with senior living executives, and then put into a nice actionable piece, also linking back to the relevant product pages to help get you real-time product information. As we noted, there are some great value-add expertise available within the site as well, but the specific call out I wanted to make is an important change that we've made to Direct Supply Network over the last few weeks. Our supply chain team has really responded, and must give them props for the work that they're doing. Not only are we giving you better information and better visibility to the product availability of our products, if something is out of stock, for example, Gojo or Purell sanitizer right now, we've removed it from our websites so that you're not going to see it, think that it's available, place an order, and then wait weeks or months in order to receive it. Anything that's listed and available on Direct Supply Network right now is available to purchase. And we've even highlighted on the main pages of the search or within the product pages themselves the relevant lead time for that product. This way you can make better, more informed decisions and act and respond as quickly as you need to. That's why we felt it was valuable to load those products links into the TELS checklist, strictly to help get you the quickest information, the quickest route to action that we could provide. Lastly, I did just want to highlight our Direct Supply Insights blog. This is off of directsupply.com, and you'll find a link here as well. Not only will this information, this webinar and its subsequent part 2 related to the CMS Focus Survey be posted on this COVID-19 landing page, but we will break down these webinars, these recordings, into smaller digestible chunks on the blog itself. So it's a great additional way for you to receive information and to really get to the timely pieces that are most important to you in a very quick manner. Lastly, I wanted to end with the thought of we really appreciate you and everything that you're doing out there. Again, with the multi-decade relationship Direct Supply has had in senior living, our industry, our marketplace, our world, and our passion is yours. And we can't thank you enough for the work that you're putting into this. So don your PPE, wash your hands, stay safe, and thank you for your time.
Thank you so much, Dustin and Kenn. Really valuable information here. Again, reiterating what Dustin said, we want to thank you all for your time today, and stay safe out there.